it is now the turn of Dr. Thiago Reis. Thiago is head of nephrology and kidney transplantation at the Clínica de Doenças Renais de Brasília in Brazil. He's researched at the Laboratory of Molecular Pharmacology at the University of Brasilia and has been affiliated and is still with the International Renal Research Institute of Vicenza, Italy, and he is member of the Brazilian Society of Nephrology. So, Thiago, welcome back to Vicenza, although in a virtual form, and please give us your knowledge and experience on the use of adsorption for liver support. Thank you.
Thank you, Professor, for the invitation, and thank you, Jafron, for sponsoring this activity. I will share my screen. So I will try to cover briefly in 40 minutes all the aspects of adsorption therapy for liver support. These are my conflict of interests. And first, covering hyperammonemia. So there is this phenomenon that occurs in the brain, in the astrocytes, when we have high concentrations of ammonia. It gets together with glutamate, making glutamine, which has a osmotic property and causes an inflow of fluid from the interstitial space towards the astrocyte, creating brain edema. So this is a serious threatening condition. And when usually ammonia is above 200 micromoles per liter, we advise to start CRRT irrespective of AKI, first with a high flow phase, an effluent of 90 ml kilograms per hour to keep ammonia below 100, and then a maintenance phase with an effluent of around 35 ml kilogram per hour. This is the statement of the last guidelines for liver failure. So CRRT should always be undertaken in critically ill patients with acute liver failure as opposed to intermittent hemodialysis. So the preferred modality for those patients is CRRT. And this is an example in the machine. So here is the dialysate flow, 5,000 miles per hour, replacement only 300 miles per hour, and an effluent, in this case here, was 79 mLs per kilogram per hour. So diffusive clearance mainly. This is the representation in the machine, so you can see the pump from dialysate and the effluent spinning fast with those that high dose. Hyperbilirubinemia and biliary acids. So this slide shows that biliary acids, they have a path through a transmembrane receptor which can activate a apoptotic path. So biliary acids, they can be toxic to the liver itself when they accumulate, and of course to renal tubule cells, causing biliary nephropathy. And in those patients, there was this debate if we could use citrate anticoagulation, and data shows that it's safe. So in this analysis, including 1,000 patients, those that had normal lactate, less than 1% had signs of citrate accumulation. Those with elevated lactate, only 2% had signs of accumulation, and those with persistent elevated lactate, only 6% had citrate accumulation. So it's a rare phenomenon. It mainly occurs in patients with severe sustained hyperlactatemia, but not in patients with liver failure. So tests for liver failure, they are not predictable. They are not good predictors for citrate accumulation. So we can claim that citrate is safe in liver failure. About the liver support systems, so first with hemoperfusion, we have these two cartridges, BS330 and HA330-II, and they can remove via adsorption this range of molecules in this range of molecular weight. And this is the representation of the beads, which are porous beads, and inside those porous, that we have the phenomenon of adsorption. So bilirubins and biliary acids, they get trapped, and the pore size determines the selective range of each of those different cartridges. So the pore size here is of paramount importance. The electron scan microscopy of those tiny beads. So this is the representation of the bead itself, and this is the surface of it with those pores. And now the representation of the extracorporeal circuit for DPMAS. So it's a therapy that takes like 2 to 3 hours, 2 to 3 times a week. The blood flow in the circuit is from 100 to 150 miles per minute. So the blood goes in this way, passes through the pump, gets the citrate coming here in this part, and then goes through a plasma filter that directs 30% of the plasma to a parallel limb of the circuit. Then we have another pump for the plasma, and finally passing through BS330 and then HA330, finally returning here in the deaeration chamber, going back to the patient. So this is a representation of DPMAS here in the circuit in the Diapact machine. We can also apply both therapies, DPMAS and CRRT, in parallel at the same time. So we can place a Y connector in the catheter, in the arterial line of the catheter, and then simultaneously 120 miles per minute of blood going through the CRRT circuit, let's say in a patient with hyperammonemia, and in parallel 120 miles per minute going through the DPMAS circuit. And then finally here they return to the patient with another Y port. Another treatment is the PAP, plasma adsorption perfusion, which is an albumin-free. You don't need to replace albumin to the patient. The catheter here, the blood passes through the blood pump, and then a plasma filter that directs 30% of plasma through a cartridge, this cartridge here, and then they merge with the rest of the blood in the bubble trap. So here in the left is the plasma filter, in the middle the cartridge, here's the machine, the warmer for the plasma. Here's a representation of the blood flow, 150 miles per minute, and here's the whole circuit. So the plasma, filter, and the cartridge. This is a treatment, and in the left we have the blood pump, and here is the pump for the plasma after it passes through the plasma filter before going to the cartridge. Another treatment for liver support is MARS, that stands for Molecular Adsorption Recirculating System. So MARS has 4 components. So here is the high flux filter in which the blood goes from up to down here and inside the capillary fibers, and in the dialysate space we have a solution of albumin. This albumin is not now, it's dirty, let's say like this, and passes through a pump and then goes into a low flux dialyzer. But in this case, the albumin goes inside the fiber, and the outside is a normal dialysate solution. This albumin passes through a activate charcoal cartridge and then a ion exchange cartridge. So this is the activate charcoal, this is the ion exchanger, and then it's let's say purified to go again in this loop. So this is a representation of the circuit, and one downside of this therapy is the need for albumin, 600 ml of albumin. Another treatment is the SPAD, that stands for single pass albumin dialysis. In this case, it's a normal CRRT machine, normal CRRT treatment. However, here that I'm pointing down in the green scale, we have a solution of 3% albumin instead of a normal dialysate. In the representation of the extracorporeal circuit, imagine if the blood is coming from the left to the right. So the blood goes in this direction, gets citrate, passes through the blood pump, and then here is the dialyzer. The albumin 3% solution as a dialysate solution goes in countercurrent with the blood, and then the blood passes through the warmer, bubble trap, gets calcium compensation, and returns to the patient. A recent paper published in Blood Purification compared patients that were submitted to SPAD and then cross over to MARS, and the results showed that the reduction of bilirubin pre and post session were equivalent both in the group SPAD and in Mars. So we don't have clinical outcomes comparing patients submitted to both modalities, but at least for this surrogate marker, so bilirubin, those treatments are equivalent. And one advantage of SPAD is that you can apply it in any service when you just need to have a CRRT machine. So it's more widely available, let's say like that. Another therapy for patients with liver failure is plasmapheresis. So this was the statement in the guidelines. Plasmapheresis has been shown to improve transplant-free survival in patients with acute liver failure. This was based on the results of this trial conducted from 1998 to 2010 with 5 centers, 182 individuals with liver failure and at least grade 2 encephalopathy. They were randomized to receive standard care or standard care plus high volume plasmapheresis, meaning to exchange 12 liters of plasma in 3 consecutive days. It was demonstrated that, so in this figure, in the x-axis, we have the time after the treatment was initiated, and here the cumulative survival. So in patients that were submitted in the end to liver transplant, there was no difference if they performed or not previously plasmapheresis. However, in those patients that were not submitted to liver transplant, those here that had treatment with high volume plasmapheresis had a better outcome when compared to patients here, the downline, that were not submitted to, that did not carry plasmapheresis. So this is briefly the representation of the circuit. Bloods get citrate, blood pump, and then here is the plasma filter, not a dialyzer anymore. And then before the blood returns to the patient, we have a replacement solution. In this case, for liver failure patients, we replace here fresh frozen plasma. This trial in China compared DPMAS versus plasmapheresis in patients with hepatitis B and acute liver failure. And as a secondary outcome, so exploratory findings, the sample size was not calculated to these outcomes. However, there were no difference in mortality comparing patients that were submitted to plasmapheresis 33 versus 14 to DPMAS. And finally, this paper from Italy compared 3 modalities of liver support. So PAP, plasma adsorption perfusion, plasmapheresis, and MARS. It was a retrospective analysis, so 66 patients that performed PAP, 15 plasma exchange, and 14 MARS. And regarding the reduction in bilirubin before and after the treatment, we can see that for PAP it was around 30%, PAX 27%, and MARS 26%. So they were equivalent. There were no statistical difference in the reduction of bilirubin comparing these 3 modalities. And the authors conclude that based on costs and duration of treatment, we suggest that PAP could be considered as a first-line approach for patients with hyperbilirubinemia. So I thank you for your attention. Let's move forward. Thank you.
So thank you very much, Thiago, for your very nice overview. I have an immediate question to ask you, just to make people understanding. What is the difference between PAP and DPMAS, except that in one case you have 1 cartridge and in the other you have 2 cartridges? What is the mechanism and the difference?
Well, adding an additional cartridge to the circuit, in the case that HA330, amplifies your magnitude of removal, because now with this other cartridge, another range of molecules can be removed, mainly inflammatory molecules that are involved in patients with acute decompensated liver failure. So this would be the additional to your already capacity to remove bilirubin and bile acids.
Why these cartridges cannot be placed in direct contact with blood?
Because this would increase the risk for clotting. So an intelligent solution was to use only plasma and avoid the use of albumin. That would be also a solution. So this is an intelligent way to overcome the problem of clotting.
Okay, so now what would be the ideal candidate for you to undergo this type of liver support therapy?
Well, as we have in the guidelines, if we detect that the patient has higher concentrations of ammonia, certainly CRRT, and to modulate the inflammatory response, applying a cartridge such as HA330, and to aiming to remove bilirubin and bile acids, also the BS330. So I think an ideal treatment could be doing in parallel, so CRRT with DPMAS.
We have done in our laboratory a series of experiments showing that the capacity of the cartridge to remove bilirubin is very high, and it can continue up to 12 hours of usage. What is your recommended timing of application and duration of application?
Well, based on data from the ERCOL trial that was performed in Italy, it was a different cartridge, but they've demonstrated that after 6 hours, the concentrations of bilirubin pre and post cartridge were the same. So demonstrating that the cartridge was already saturated. So I would say something between 6 to 12 hours.
It depends, of course, on the concentration of the solute, because the isotherm that governs saturation of the cartridge depends on the flow you're using and depends on the initial concentration. The higher is the concentration, the sooner the saturation may occur. Now, one question, what blood flow would you advise and what plasma flow would you advise, and what is the amount of plasma that in your opinion should be circulated?
Well, so blood flow, I would say 150 mLs per minute. So in this case, we have around 120 mLs per minute of plasma passing through the plasma filter, and then we direct 30 mLs per minute. That would give us a filtration fraction of 30%, which is okay not to avoid clotting if we go further, let's say 40% of filtration fraction. So a blood flow of 150, a plasma in the parallel limb of 30 mLs per minute, and treating around 5 liters of blood that usually of plasma that usually equivalent to 1.5 volemia of plasma of those patients. And in these settings, the therapy, the session would take like 3 to 4 hours, I'd say.
Do you have a preferred anticoagulant in this case?
Yes, I am a completely fan of Citrate. So I think it's safe. We have already data for that. And so I would advise using 4% sodium citrate as an anticoagulant.
But isn't that true that if you have a liver failure, citrate cannot be easily converted and you have a risk of accumulation?
Yes, there is this risk, but as citrate is also metabolized in the musculature, also in the kidneys themselves, so we can measure, and we are dealing with short sessions of 6 to 12 hours. We would expect citrate accumulation in CRT for, let's say, 48 hours, 72 hours, and we can measure those parameters every 6 hours. So I think we can predict if citrate will accumulate or not.
One last question. What would be your ideal candidate for endpoints in case of a randomized study?
So as endpoints, I would say 3-day ventilatory free days. I would say days without drugs in the ICU, without vasopressors, days without sedation, and especially in liver failure patients, neurological outcomes. So days without sedation, sequel after patients are outside the hospital. So I would use this as outcomes.
Okay, I think we have come to the conclusion of this sponsored symposium. I would like to thank Dr. Rakhi for presenting her experience, Dr. Thiago for the nice overview and the nice question and answer interaction. So let's go back to the scientific program of the 39 Vicenza course on AKI and CRRT.